engaged in. And I would also, in terms of handling the whole COVID thing, i.e. transfers, keeping people separated when they were testing positive as opposed to letting them commingle. And also of significant concern is the mental health aspect. What services are there for, especially for children who are, it's hard enough for them to be in a detention facility, but now with this whole COVID thing, if you could just touch on the whole mental health aspect as well.
Well, thank you for that question. There's so much, as you know, packed into that question. I'd like to start by saying something we've all started to talk about. You know, those of us who are intimately familiar with the immigration detention system know that it's immense, it's scattered, it's fragmented. There are so many different facilities trying to provide care. And for some time, owing to its structure, have faced challenges in meeting their own standards. I'd like to echo that the standards themselves could be improved. It's something we could talk about. So when COVID started to declare itself in the early part of the year, this is when my colleagues and I became enormously alarmed. We had intimate knowledge about the capabilities and vulnerabilities of the system in responding to this very great threat. And we felt obliged because of the danger literally to health, safety, life, and limb, not only of the detainees, but staff and surrounding communities. How detention centers as congregate settings can promote spread not only in the center, but through surrounding communities, through employees coming and going. And we, as I said in my opening statement, made a very urgent effort to alert leadership that they really needed to do some dramatic things to try to head off the threat. As we well know, our main recommendations were not heeded, and the public record shows the outcome, that we've had a significant number of outbreaks. I'm glad you brought up mental health, and particularly the important and ongoing issue of detaining of families with children during the time of a pandemic. There's already very harmful health effects, immediate and long-term, that can affect developing children simply associated with detention alone, even if everything else about the detention is so-called perfect. Isolation from therapeutic community, the stress of indefinite confinement, and so forth. But you add to that being trapped in a congregate setting when everything we read says, get out of congregate settings, try to create social distance if you can't, isolate yourself within a household unit. That only adds to the stress. And I think anyone listening can only maybe pause for a moment and imagine themselves in that situation. It would be enormously stressful for you, and particularly if you were worried about your children.
So, I mean, I guess this is more of a comment, but maybe if anyone else wants to, any of our witnesses want to comment on this. It seems to me that regardless of what the immigration policy is of whomever is in the White House, pro or not, that we as congressional members with the constitutional responsibility of oversight of these federal agencies and how they operate should demand and institute a basic level of care that is not regardless of who, just a basic standard of care, right? I mean, Dr. Allen or Dr. Schreier or Ms. Rivera, if you'd just like to comment. I mean, maybe it sounds like an overly political thing, but the treatment of migrants should not be subject to the vagaries of a political policy that could change as frequently as every 4 years. Dr. Schreier, you have to unmute.
Well, if I just might respond, from a medical perspective, you're absolutely correct. The standards are independent of politics. Medical standards are determined by the profession, by the evidence, by the science, but also by professional respect for human rights and human dignity, as others have referred to. Those are woven into the standards of care, and which is why, as part of our response, tightening up and addressing the standards and make sure that we use standards that we would expect if our own family members were so detained, that it should be no less. entirely separate and related to any other thoughts you might have about the purposes of detention and other issues related to detention. When we're talking about health care, mental health care, and safety, as well as public health, these issues supersede all of the politics or basic human rights, and there are medical standards that we use regularly every day in the community.
Dr. Shrira? Oh, you have to unmute again.
How's that now?
Great, now we got you.
Thank you. I worry so that ICE uses primarily correctional facilities for the detention of civil detainees. It really communicates to the public a sense of dangerousness, which does not exist. And the physical plant is also often the plan for managing people. When you take a low-risk population and you put them in high custody housing, and then you dress them out in jumpsuits, and you have them do standing counts 5 and 7 times a day, it's everything is upside down, and it perpetuates a perception with the public that allows that to continue. I think the groundswell would be more pronounced if there was a better understanding of the differences. And that's also why I emphasized the need to have standards that are not based on those that govern correctional systems, but that are suitable and consistent with the case law for a civilly detained population. Punishment is expressly prohibited. Period. Stop. And yet so much of what the committee observed and captured in its report is nothing less than punishment. The extensive use of punitive segregation, use of punitive segregation without any due process, denying them medical conditions consistent with a standard of care, which is something you would receive in a correctional system, is denied them just by virtue of the combination of ignorance and lack of oversight that each of us has been describing this afternoon.
Ms. Rivera?
Yes, I think the main point here is that simply promulgating more detailed or higher standards on paper will not resolve the systemic problems of the ICE detention system. The facilities used are prisons. The economic incentive is perverse and increasing, centralizing wealth in the hands of a few corporations. That the oversight system is actually built to enable, not correct, deficiencies. And so putting ourselves in the shoes of people inside, I think, is the greatest experts to understand what it must feel like to come to this country seeking asylum or to be here for years with your family and working, being a member of your community, and all of a sudden treated as subhuman and abused on a daily basis, eating rotten food, water that is not fit for consumption, charged $10 for a 15-minute phone call with a loved one, denied access to an attorney who can help. Your family tries to visit and they can't bring in pens and paper to help you with your legal case. An ICE deportation officer doesn't come to visit. You have no idea what's going on with your case. You don't know how to fight it. This is a sort of Kafkaesque setting that is commonplace in facilities across the country, and particularly from what I have seen in Georgia and Louisiana. And so really the obligation of the members of Congress, I think, is to look at that 30,000-foot view and ensure that we push forward a paradigm shift towards something more positive than we have now.
Ms. Watson Coleman, do you have any questions?
Oh, yes. Thank you so much for being here. I read the report, the committee's report on this, and I was just struck by so many things. The fact that you couldn't get toothpaste or soap or a toothbrush unless you encountered a friendly guard. when you were in need. The fact that you had to actually clean your space, yet there were millions of dollars that were being spent for just that purpose through the contractor. And the fact that they're using a contractor, Nakamoto, that every time we've had that Ms. Nakamoto in front of us, she's not been able to answer our questions. She doesn't really have a good understanding of what's happening. But the one thing that was consistent is that they aren't doing their job well. And I agree with you 100% that the facilities in and of themselves are the incorrect facilities to house people who are under civil detention. But I also don't understand, Dr. Shiroro, you said that that the federal government only owns 7 facilities.
That's correct.
But that it uses 100 and some private facilities, right?
As many as 232.
And you said that the 7 facilities that the feds own, they don't use?
They're filled, but they don't operate them. They use the private sector to run those facilities that are government owned.
So all of the facilities that house these detainees are run by private organizations with contracts from ICE, right?
Not exactly, ma'am. It's a combination of the private sector. There are 4 big groups, and then quite a few sheriff's departments and other forms of local law enforcement. But again,
okay, they may be local or county government facilities, but they're operating with this with this relationship where the feds pay this money to house those individuals.
That is correct.
What percentage of the individuals, to your knowledge, and Dr. Allen and Ms. Rivera, you can respond to this as well. What percentage of the individuals that are detained currently do you think could be held accountable without being held in a detention facility?
I'll start. The majority are assessed to be low custody, and more instructive than that, ICE has another way of assessing people. They assign them a threat risk, and the vast majority of the population has either, according to ICE, this is them saying it, either present no risk to the public or low risk. And so that group, as well as some in the middle, are more than suitable for release. And I would argue release without conditions, and then only when necessary with alternatives to detention.
So other than just treating human beings as subhuman beings, and other than putting big money in the hands of big donors, what is the motivation then for these individuals being detained as opposed to being in the community, continuing to be productive, no threat to physically harming anybody, certainly no threat to, going back to wherever they, ICE thinks it wants to deport them, but they wouldn't come here in the first place. What is the motivation for treating these individuals as subhuman, as criminals, and with disrespect and disregard for their health and well-being?
My view is that ICE is fundamentally an enforcement agency. It has little expertise and, quite frankly, little interest in operating a detention system or alternatives to detention. But as enforcement staff, if they know that this individual is right here, and if their case starts to move, that they can then do something with them, that's expedient for them. It comes at great cost to us, and certainly at considerable harm to the population that's being held, but they're the ones that are in charge. There hadn't been a lot of research for a long time as to how much you can count on an individual who is released to report as required and if necessary, report for removal if that's the outcome. There are increasingly very strong studies that demonstrate all the safety that the population presents, and that we can add to the extent that it's necessary. But even when ICE as an organization releases people to an alternative, it tends to over-supervise them. It just loads them up, with electronic monitoring and lots of reporting, which is for the vast majority of them also unnecessary.
It seems to me that the Department of Homeland Security has one problem after another. In just about everything that, we've had an opportunity to have a hearing on in Homeland Security. And it seems to me that when we're talking about this particular issue, ICE has not been trained to do what is intended for these people who are detained civilly. Do you, Ms. Rivera and Dr. Allen and Dr. Schroer, do you believe that we need to eliminate ICE and start all over again? I'll start with you, Dr. Allen, and go to you, Ms. Rivera, and end with Doc.
Well, I have to just confess that is such a policy question that's beyond my area of expertise that I'm lending to this discussion in committee. But I will simply say that your report documents a number of the problems and human costs in the current system. We definitely have to work to address that. It's a really much bigger discussion than I could comment on about the structure of the department and how it should improve. But certainly in the area of keeping people healthy and safe, there are significant problems.
Thank you, Ms. Rivera.
Thank you. I don't see any other way to deal with the scale of the systemic problem here than to dismantle a broken, an agency that is working to suppress and cage Black, Brown, and Indigenous people. I think that, over the past several months during COVID, we have seen the human cost exacerbated by continuing to cage people in spite of scientists saying that we need social distancing. You asked how many people could be out of jail while their cases are pending. Well, if you look to the federal prison system, Attorney General William Barr himself ordered the Bureau of Prisons to conduct a top to bottom review of everyone in custody and to release people who had infirmities. That did not happen on the ICE side. Yet another sign that this agency is a political tool that uses migrants as scapegoats to advance the political aims of their very few. So how many people could be out of jail while their cases are pending? I would venture to say all. These are civil cases. The vast majority of people, the data shows, report to court, report to ICE, fulfill their obligations for their cases because they have an incentive to play by the rules. And the why, the question that you asked earlier, why is this done besides profit, and besides, to perpetuate the system, I think again goes back to this notion of white supremacy. Our nation is at a crossroads right now with Black and Indigenous and other people of color leading a charge to say enough is enough. We will not be over-policed. We will not be the target of a racist new Jim Crow system. And Michelle Alexander said in her book that mass incarceration has been the chief tool for the maintenance of white supremacy in the 20th and now 21st centuries. And this is just another example of that and another arena in which that logic plays out. And now most Americans are opening their eyes to the reality and insisting that we make real and substantial change.
Hope so. Dr. Ferraro?
Yeah, thank you. We went tough on crime in the 1990s and paid a terrible price. And as corrections wised up and started to release lots of people, well, divert them at the front end and release them much quicker from, once they were inside, all those beds opened up, and then ICE took them. And ICE has not yet learn the lessons that that the criminal justice system has learned, not necessarily on their own. There were lots of litigation, but ultimately a lot of improvement on the criminal justice side of things. ICE does not have a critical mass of individuals in it capable of making evidence-based decisions about the risks that individuals do or don't present, and then arranging systems of supervision commensurate with their needs. I'll point out that Secretary Napolitano, for whom I served, had first had me as senior advisor, and then I had the great opportunity to open the Office of Detention Policy and Planning, and it was there that the system, as we are describing it today, could have been carried out. One of the first things that was changed in the current administration was the elimination of that office. So there will always be some decisions to be made, whether it's ICE or some other entity, but clearly one has to have an appreciation of immigration law. You can't just take corrections people and have them do this either. This is an expertise that needs to be developed. I'm confident there are plenty of folks, you've got 3 right here today, and many more out there that can create a thoughtful system that will be cost effective and fair. But that's gonna take some change from the legislature, if not from the executive branch.
Thank you. Chairwoman Rice, I'm going to yield back to you because I know I've taken advantage of your graces here, but I hope we can have the chance for some more conversation with our excellent panels.
Absolutely. This is all about. Thank you so much. Ms. Barragán?
Well, thank you all for raising these issues. I'm disturbed. I agree with Ms. Rivera on the concern of the for-profit private contractors. I think we need to find a way to put an end to that. We see report after report coming out from the Inspector General about deficiencies, and it just seems that these reports come out, but then there is no real way to ensure that they're correcting them and that there are consequences if you don't correct them. So then there's just this pattern happening over and over again. And then now, from what we've just learned this week, of uninformed procedures and hysterectomies, I mean, it is just so shocking and appalling. And now we're seeing more deaths with migrants that we hadn't seen in the past. And so it just seems to me that what we're doing isn't working. And the oversight that's being provided, while we can call for another investigation, it just doesn't lead to consequences. And I think that's kind of what people, at least that I talk to, say, what more has to be done before we shut them down, or what more has to be done before there's real consequences. Dr. Shiriro, in a report that you authored in 2009 for former Secretary Napolitano, you discussed 7 buckets of issues that have plagued ICE detention, particularly on the lack of oversight of these facilities. Now, ICE has implemented some of the measures you recommended, but as found in the report, those oversight tools frequently miss deficiencies and leave them uncorrected, really. Can you speak more to this issue and how oversight measures can better be utilized to ensure the deficiencies are corrected? And, are those recommendations going to put an end to this? And outside of ending the use of private contractors, how do we get there? Because I think that is the bottom line. How do we really stop this?
Yeah. Thank you for the question. And you actually use my language. I always talked about the buckets. So I'll go to one of the first buckets, which is really creating a strategy for the people that may be in the custody of the government, whether and I use custody broadly, so I'm not just talking detention, but anyone who is awaiting a proceeding before the immigration courts. ICE is missing many things, and one of them is a bed plan. That's a correctional term, but it really speaks to how many people are you likely to have? What is the continuum of control from nothing, which I've talked a lot about, to someone who might need to be confined, and then confined under what conditions? ICE has been in existence 18 years now, and it has not done anything but reach out to available beds that are nearby or far away and pay whatever they have to pay to acquire those beds. As I described it, they have a situation that's next to impossible to manage. 232 facilities, 46 states. You've got... It's well over 100. I just couldn't count them all. But you've got these big private prison providers. The four big ones are just four in number, but they manage over 60% of all of ICE's beds. Just focusing there, where you only have to command the attention of those four agencies, you can achieve a really big impact fairly quickly. You need a team with experts in the field of medicine and other places to, be specialized and look at each of those areas. But I believe that you can move quickly. We did move quickly in the time that I was there. Unfortunately, a lot of the things that happen unravel, and so we have to round them up and do them again. An example, Nakamoto was in place when I was there, and their services were terminated. When I was there, it was actually a decision on the part of the procurement officers that all the inspections would be announced daytimes, business days, business hours. These are people who have expertise in procurement, maybe, but they have no expertise in the actual subjects of the goods and services that they're procuring. And so that was reversed immediately. And as I read in the report, that had been undone as well. So this requires continuous oversight. On the accountability side, having good information real time available on the website is critical. And ICE is not forthcoming with the information that it provides. I was pleased to see, as a result of an appropriations amendment, that there is new information that's on the DHS website that hadn't appeared previously. That's where I was able to get my information, for example, about guaranteed minimums. I knew that it existed, but now I can see which facilities have guaranteed minimums. But even now, ICE does not indicate what is the bed capacity of each of those facilities. And every conversation begins and ends there. When you're talking about COVID and social distancing, and they talk about having reduced the numbers, that does nobody any good if they're still keeping housing units filled and then just leaving some empty, which is only increasing the profit of who's ever operating those facilities. So I tend to be optimistic that a lot of things can happen quickly, but you need to have them happen quickly.
Well, thank you. I think it's really important that we remind the public that it is legal to come and apply for asylum. It is legal to come to this country, to go to a port of entry, and to apply for asylum. And what we're doing then is we're either turning people away these days or putting them into these facilities that are really prisons. I mean, I remember visiting the first detention center, and I said, "What's this prison called?" They said, "Oh, it's a detention center." I said, you can call it what you want to call it, but it looks like a prison. You walk in, it feels like a prison. And to some degree, these migrants are treated worse than prisoners, where there at least there's some accountability, there's access to counsel, in our American prison system. So it is completely an effort. And I think under this administration, they have admitted they're doing whatever they can to deter, and that sometimes includes inhumane practices like separating children and parents. And even when members of Congress go to provide oversight visits, they're given notice. I don't think they should have to receive any notice. I feel like I should be able to walk up same day, show my congressional ID, and walk in and do an oversight visit. And worse, sometimes we get to these facilities and they don't even want you to talk to the detainees. I'm like, what is there to hide? If you're doing everything on the up and up and they have nothing to complain about, like, what, I mean, what is the issue here? That continues to happen to members of Congress when we go to these facilities. It's, well, we don't want you to talk to the detainees, or you need to make an appointment, or you need to talk to their lawyer first. There's always something. And it feels like, and it looks like a prison. There's just no other way to put it. And then when you hear about the practices of segregation and punishment, it just seems to be completely backwards and not what was intended.
identified if they do pose a danger. We can have a well-staffed administration to go through the cases of people. We can have a set of laws and rules that are manageable, that are consistently applied, instead of the current patchwork of the immigration courts with its myriad confusing laws and decisions that differ all over the place. So I think if we use our imagination and are guided by our values of welcoming the other and valuing the immigrants who bring so much to the richness of our country, there really are more constructive alternatives than incarcerating, surveilling and punishing.
One of
Go ahead.
One of the first pieces of legislation I introduced when coming to Congress was prohibiting the use of for-profit and private prisons, because I think if you're going to use them, you're going to need a population for them. And so it sort of was counterintuitive to any kind of reform measure. And mostly we were talking about criminal justice reform, but it's extended beyond that now, as we see. Nakamoto has a $71 million contract with the Department of Homeland Security's whatever procurement office to continue to do these inspections. And it does not do these inspections well, even when it announces that it's coming to a facility weeks before it gets there. And then it does mention from time to time some sort of minor problems with the facility when there are major problems with the facility. And I think that an inspector general needs to really look into Nakamoto and how it does its job. I don't think you can hire enough people in an agency to do the kind of oversight when you're locking up people who don't need to be locked up and detained in the first place. I think that the policies need to change as it relates to that, but the policies and the laws need to be, and the standards need to be applied universally. Not different in Georgia than they are in Louisiana, and they are in Texas, and they are in Maryland. Now, Dr. Ferraro, you said there are the 4 largest facilities. If we just kind of like focused on them for a minute, maybe we could have some impact here. Is one of them, is one of the organizations LaSalle?
So what I was referring to, the facility providers, it's more than 4 facilities, but so LaSalle Corrections is one of the 4. Yes, ma'am.
And who are the other 3?
Core Civic. It used to be known as CCA, or Corrections Corporation of America. The 3rd is MTC, Management Training Corporation, I think is what that stands for. And then and the 4th is the GEO Group.
GEO?
That's correct. GEO and Core Civic are the 2 largest.
My understanding is that the LaSalle Group, that government had removed its prisoners from the LaSalle Group because of conditions. Is that, do you have that recollection?
I'm not familiar with that. I could certainly look at it for you. But it's a combination of either jurisdictions deciding to cancel contracts, or through reforms, as I was mentioning before, that they've figured out how to reduce their population so they don't need it anymore.
I have one last question, burning question. Not really, but I'll just go with this one last question. You take innocent people who are somewhat scared anyway because they don't have the right documentation and they're in our country, but they've been here a while and they're not causing any problems. And you put them in prison-like a setting, and they've been in that setting for months. Is that about right? Months?
Yes.
Longer?
In some occasions, yes.
Does it change their perception of themselves their relationship with society, and so that when they are released because policies change, do they come back into society different people with creating different problems? And Dr. Allen, I don't know if you want to speak to that or.
Yeah. No, it's a terrific question and something that's foremost on my mind and my colleagues' mind all of the time. It's sort of a point a lot of the speakers keep returning to. We are talking about what we are doing to human beings. And there is no form of confinement that I'm aware of that is, therapeutic or helpful. Generally, all forms of confinement as it relates to immigration and law enforcement carry costs of mental health stresses, but also physical health stresses. We don't have to go any further than COVID, as well as other infectious diseases, to illustrate the adverse effects not only on the health and future health of the detainees, the staff, but also our communities. So from a health perspective, these programs are potentially very damaging to individuals, not just in the short term, but there's a rich literature on long-term adverse health effects of people who are confined. I can't comment on this without bringing it back to detaining children with the rich literature, the universal opposition of the entire medical profession, from the American Medical Association, the American Psychiatric Association, American College of Physicians, all the way on down. And the science on that is clear, but there's been a deaf ear in responding to the humanity of that, or to recognize the long-term costs and the cost of trauma on mental health and physical health. Doesn't affect just the people who were incarcerated or detained. It affects their communities and their families. Again, a rich literature on all this. So it's very distressing to watch all of this happen as a health professional involved with the system. I do want to take a moment to bring it back to where a few of you started in your open comments. Let's recognize that in this excellent report that I agree everything in, I want to point out that the Dawn Wooten, the nurse at Irwin, who made disclosures last week, is one mechanism that we didn't explicitly talk about in the report, and that's whistleblowing. And I think when we're talking about all the failures of the other mechanisms, this is when whistleblowing becomes important. I should quickly add that Dawn Wooten is represented by the same attorneys I am in my disclosures. That's Government Accountability Project. There's a firewall between us, but I should disclose that in commenting. But I salute, in principle, what she has done as a health professional, because when we say that government has not done a good job at meeting these basic human rights standards, it falls to professionals to stand up and speak their conscience and bring attention to violations of people's rights. So let's remember that, to the fact that we're now relying so much on whistleblowers to bring these problems to attention, is enough evidence of problems in the current oversight structure.
It shames me, it hurts me, and it angers me.
And that's a really good point, Dr. Allen. I want, there are three things I think that I've been in trouble with this situation in Georgia. Well, there's a lot more than three, but three that I just want to see if we can come back to for a second. Number one is this concept of uninformed consent, that there's a language barrier and a language issue. Has there been any efforts or thoughts about maybe video recording some of these conversations to make sure that there is actual translation and informed consent? I mean, I think to when somebody's interrogated and it's video recorded. And so before you're going to go into a big procedure, why not just have a conversation with the person on camera? Is there some concern about that, just to make sure that they have, we have documentation that they knew what was going to happen and what they were told was going to happen actually occurred? Because unfortunately, we've seen in today's day and age that body cameras, law enforcement has helped reveal things that in the past, something was said and it didn't happen that way. So I'm wondering if there's been any conversation, discussion, or if there might be any use of ensuring that there is that that the language barrier goes away by maybe having some of these conversations recorded when it's such a critical decision like a surgery, so there's an understanding. Number two, Dr. Shiriro, maybe you can talk about this, is how the heck do we have doctors with questionable past providing procedures to people in these facilities that are government, they're under the care of the government, and we have the responsibility of them. Is there any process in place so that questionable doctors are not performing these procedures? And has there ever been a conversation about whether something that rises to this level of uninformed consent on what we're hearing in Georgia be considered on charging a crime? I can't imagine as a woman, I want to have children, and I come out of a procedure being told, by the way, you cannot have children now because of what we did, even though you didn't agree with it. I mean, that to me is a crime. And so I'm curious if maybe Dr. Shiro, you can start and then see if we can hear from our other panelists on any thoughts on these.
Okay, so I'll start with your latter questions about doctors and nurses who have restrictions on their licenses. You know, everything begins and ends with ICE. They are ultimately responsible for the care and custody of all of these individuals, and it's largely their practice, as each of you have pointed out, that they hand them off to the facilities, have Nakamoto pop in once a year and say that's that. And as I mentioned, in Nakamoto, everybody meets standards or better. So that's there's an office within ICE. It's called ICE Health Services Commission and IHSC, and they deliver the direct health care at only about 22 facilities out of the 232, but they do establish some of the policies that are supposed to apply across the board. In my view, they're not a stellar organization. So I'm hesitant to suggest that they should do more, but there should be individuals with expertise in healthcare embedded within ICE that provide oversight of all of the healthcare that is provided across the board. One of the things that COVID really brought out is that facilities went from having maybe a part-time physician or someone less, maybe 2 half days a week, to relatively large staffings. There are no expectations set, and this is a terrific deficiency on the part of ICE. And similarly, you know, that it's not that you should just have X number of people, but as you point out, that they ought to be fully credentialed without any restrictions, without, you know, previous practices that would cause anybody concern about hiring them. The last thing I'll say about IHSC specific to this awful situation is they are basically like a cost control center of not necessarily the good kind. And so any kind of offsite visit that is going to take place must be pre-approved by ICE, by IHSC, except in, you know, extraordinary exigent circumstances, and perhaps Dr. Scott can jump in on that as well. And so their usual position is to say no, not yes. And so, you know, it's that much more onerous that some number of women have left the facility for offsite care. The procedure is known to ICE, even if it changes after the fact. And at no point does it appear that they're looking at it to spot, well, what is this this pattern that seems to be evolving? So for me, there are you know, many more questions about not just what the facility and LaSalle as the provider is doing, but ICE, you know, who's ultimately responsible Where are they in all of this? And you know, what is their response? What opportunities to improve do they see? And how quickly are they going to take them?
And I'd like to just follow up on that point. You know, I not just related to ICE and all of the correctional detention work I've done over the years. Almost everyone now uses some hybrid of government and private contracting. And it's a common pitfall. I often have to remind people that you can contract out the work, but you can't contract out the responsibility. This is and this phenomenon also illustrates the challenge of these very complex systems. So when we're talking about care provided at facilities, there's care provided within the facilities by providers, doctors, nurses, and so forth, who work in the facility. And then when you get to emergency care, hospital care, subspecialty consultation, that in almost all settings is done offsite with community partners that these facilities negotiate contracts with practice groups and practices one by one. You know, that creates, you know, we talk about a system that's unmanageable. How do you assure quality? We can see how difficult it is to adequately credential staff who work within the facility full time. How do you possibly stay on top of the quality of care being rendered at all of your contracts? And yet you have a responsibility to do that. So that is something that needs to be thought about more, and solutions on how you would better guarantee that who you were sending someone to was qualified. But I do want to return to that first part of the question. You know, the issue of informed consent is a bedrock of medical ethics. So this is not, you know, we're not just talking about malpractice or something like that. We're talking about the, you know, foundations of the practice of medicine. And it is true that when there's a language barrier, informed consent is imperiled. The idea of videotaping a informed consent conversation between the patient and their physician carries one obvious problem, and that is that of confidentiality, that conversation needs to take place in a, you know, cone of confidentiality. That doesn't preclude that the patient could waive their confidentiality for purposes of recording the conversation. But now you have another problem. You have to get a doctor who doesn't have to take contracts with ICE and see their detainees, who says, I don't do this in my regular practice. I sure don't want to do it for you guys. I'll just stop seeing your patients. So it's a thorny issue. That solution might be harder to execute than it might first seem. However, there are ways of monitoring whether translation services were properly used. I won't go into detail, but those of us who audit facilities know how to do that. There's multiple levels to that verification process. And there also might be ways to make sure that there is some sort of person in an advocacy position. It should be the physician and the nurse in the facility who can guarantee that recommended procedures are indeed clinically indicated, and more importantly, that the primary doctors and nurses at the facility have themselves had an informed consent discussion about whether a procedure is really necessary.
Thank you.
Well, I could do this all afternoon, but we do have some time constraints. So I just want to thank all of our panelists. Any solution that we as Congress members come up with, we're going to rely on you and your areas of expertise, because you know how things should run. And we are all in a position as Congresspeople with oversight over these specific agencies to implement the changes that you have time and time again suggested. And it must be, you must feel like sometimes you're banging your head against a brick wall. Like, when are these people going to start listening to us? We know what changes need to be made. Now they just need to do them. And I'm hoping that will happen sometime, next year. We'll get a better grip on, the treatment of migrants in our custody and begin to implement some of the changes that you've made. So I want to thank my friends and colleagues, Bonnie and Nanette. Bonnie Watson Coleman and Nanette Barragán, and all three of our witnesses. Thank you so much for taking the time. Again, I apologize for us getting off to a late start, but I'd like to continue this conversation, and we'd like to keep you all in this conversation with us. And we look forward to having those conversations sooner rather than later. And I'd like to thank the staff for putting together this wonderful panel. Thank you all for participating.
Thank you
very much.
Stay safe.